I'm Dr. Amy Lessin. I'm pleased to see some folks here again tonight, and welcome. I'm Associate Professor at the Dillard University Minority Health and Health Disparities Research Center. We're very pleased to have you here for the second night of our symposium. And our guest tonight, my colleague, Dr. Peter Foss. And I will turn it over to Dr. Yolanda Page, who is the Vice President for Academic Affairs and our Provost here at Dillard, to say a few words before we get started.
Good evening, everyone. I am Yolanda Page, Vice President for Academic Affairs here at Dillard University, and I would like to thank all of you for joining us this evening for the second night of our symposium. It is our pleasure to provide this opportunity for you to learn and discuss more about this challenging pandemic that is facing not only our city, our state, but our nation and our world. The Minority Health and Health Disparities Research Center here at Dillard University is funded through a grant that a research and endowment grant that the university received through the National Endowment, from the NIH, the National Institute of Health. The focus of our program is to provide community programming. Some of you may be aware of the community programming we have hosted in response to the COVID-19 pandemic, which has included COVID-19 testing, as well as some informational seminars on, as well as a a flu vaccine clinic just 2 weeks ago. Tonight, we are pleased to have one of our researchers here to share with you some insights about the health disparity amongst particularly communities of color as it relates to COVID-19. So I'm going to turn it back over to Dr. Lessin, who will introduce our speaker for the evening.
Thank you so much, Dr. Page. And I also wanted to introduce the woman literally behind the curtain, Tiffany Kirkwood, who is our coordinator of programs, and she's here doing the tech and helping us. She's helped us all along with planning and programming this event. So I'm very pleased to introduce Dr. Peter Foss tonight. He is a research professor at the Minority Health and Health Disparities Research Center at Dillard University, as well as a faculty member in our public health school as well. Dr. Foss is a decision scientist and a healthcare administration educator. He received a Doctor of Dental Surgery. He has many degrees in many areas of expertise. He received a Doctor of Dental Surgery degree from Louisiana State University, dentistry school, a PhD in healthcare decision analysis from Tulane, and a Master of Public Health in Health Systems Management from Tulane School of Public Health and Tropical Medicine. His undergraduate degree in biological sciences is from UNO. He's born and raised New Orleanian. And he was for 17 years at the Tulane University School of Public Health and Tropical Medicine as a professor, program director, research center director, and assistant dean. And in 2012, Dr. Foss returned to his alma mater, UNO, as the university president until 2016. And we're very lucky and pleased to have him with us at Dillard. And tonight he's going to talk about some of the research he's been doing during the pandemic. And he has a presentation and is looking forward to your Q&A as well. So Dr. Foss.
Thank you, Dr. Lessin and Dr. Page. It's my pleasure. Again, I extend my welcome too for those of you who are listening in on our symposium. And I will share my screen if that's okay. I'm very excited about this symposium because it gives us a chance to talk about some of the research that our center is doing. And my title tonight is that COVID-19 is a health disparity. And that's what our research has been centered around after the last few months. And I'll explain it to you during my presentation. My colleague, Dr. Lessin, we had a conversation back in middle March. We wasn't sure what was going on with COVID-19. And she had kind of told me on a telephone conversation that she had some friends who were healthcare professionals who kept telling her that there was all the people in the hospital were people of color. So she wrote a guest column in The Advocate titled "Coronavirus Will Exacerbate Existing Health Inequities." And I'm just going to read the highlighted part in yellow. Now, remember, this is March 25th. So we're very likely to see disproportionate numbers of poor people and people of color get sick and die from COVID-19 in New Orleans and Louisiana and across the nation. Now, unfortunately, she was prophetic. That's exactly what happened. So after our conversation, and she published this guest column, it spurred me to kind of look into it a little bit deep and actually do some research about it. So what we now know, and we knew back then, was that COVID-19 is really the most devastating event that's ever happened in the world. There's nothing like it since the Spanish flu pandemic of 1918, which, by the way, lasted 2 years. It ended in 1920. 500,000 people died in the United States, if I remember correctly. Several million died across the world. And what we now have begun to see is that COVID-19 particularly has been severe in the United States, relative to both the cases, hospitalizations, and the people who died. And as it's progressed, and I will tell you why I can say this with some certainty, is that we learned that COVID is not randomly distributed. Most infectious diseases pick on those people who are vulnerable, different type of immune systems, et cetera, or things like that. COVID actually picks on particular subpopulations in our population, so it's not randomly distributed. So what we found is that there's been a disproportionate number of both cases and deaths have occurred in different racial minorities. And I started to look at it and saying, well, there's got to be something that's contributing to these particular differences in the number of cases and deaths. So I went to the literature and I started investigating and decided to see where COVID was going on around the world. We all pretty sure it started in China, but there's a map that shows you where it is. It's actually in most countries of the world, and that's what we're tracking it now. So what I did was I said, let me go ahead and see what's the research that's been published about China. Now remember, this is late last week of March, and at that time, our government said that it was a China problem. We shouldn't worry about it. Our current president, stopped travel back and forth to China. Everybody thought that was the cure. And we really thought that was going to reduce the risk and it wouldn't be a problem. Of course, we all know that wasn't true. So we're now in the midst of arguably the worst ever pandemic experience in our country for sure, and in other countries across the world. So I said, let me see, I'm a researcher, let me see what the research shows about the people who became infected and died in China. And actually I found a great number of articles that were published in late February and early March. One particular study looked at those cases that were confirmed by laboratory tests. So we knew for sure that they were COVID cases, and looked to see what was the time from which the people were diagnosed till they died. It was only 18.5 days. That's pretty quick. And the case fatality rate was 28%. That means 28% of the people who got infected died. That's unbelievably high. That's extraordinarily high. And that sort of target and set the alarms off across the world. So, and also those people who actually didn't die in the hospital and were released usually spent 22 days in the hospital. But to me, the bit of information that really struck me was half the people who were hospitalized had hypertension and diabetes as well. And about 8% of the people had coronary heart disease. So I started to think about who in our country has hypertension and diabetes. So I looked at another study that looked at 1,500 hospitalized people in 31 hospitals. It's a very, very, very large study. And what they found was more than half of the people who were in the hospital had a comorbidity, had another chronic disease that was affecting them. And again, the most common was diabetes, hypertension, and cardiovascular disease. So you might be beginning to see a little theme of why people are infected and why they're dying. So I looked at another study. This was a meta-analysis that looked at 8 additional studies. And what they revealed was the most common comorbidity was hypertension and diabetes. Also, they found other comorbidities that were pretty prevalent, cardiovascular disease and respiratory disease. And what they found was that if you were infected with COVID-19, there was a 2.3 times greater chance that you also had hypertension. That's really significant. I looked at another study. I'm a researcher, I look at studies, and it's evaluated the effect of COVID on the cardiovascular system. So they found that in addition to respiratory problems, people began to start having cardiovascular issues. And those of us who follow sports will remember that college football teams, especially on the West Coast, decided not to start the season on time because they're worried about the latent cardiovascular disease that the football players may have. This study found that in addition to the cardiovascular disease, those people had a higher risk of death if they were infected by COVID-19. So now we know diabetes, hypertension, and for sure cardiovascular disease predisposes you, increases your risk for death if you're infected by COVID-19. So I said, well, let's look to see who in the United States has these particular diseases. Well, first of all, diabetes and cardiovascular disease are very intimately linked. Diabetes, people with diabetes typically have hypertension, typically have some other cardiovascular disease. So we looked at disease-related risk factors for diabetes also is dyslipidemia, which means your lipids are off, hypertension, obesity, hypoglycemia, high blood sugar, and insulin resistance. And it also shown that a major cause of deaths in patients with diabetes is cardiovascular disease. This is in the US. And patients with type 2 diabetes are 2 to 4 times more likely to have coronary artery disease. So prior to COVID, we knew that diabetes and cardiovascular disease were intimately linked. And if you had diabetes, you had higher risk of getting coronary artery disease and actually dying with cardiovascular disease. So another study I looked at looked at the prevalence of people with type 2 diabetes and found that the amount of type 2 diabetes, the prevalence is going up, and it's closely linked to obesity. So now we got diabetes, hypertension, cardiovascular disease, and obesity is a comorbidity that's increasing your risk for COVID-19 deaths. Now, so let's look who has diabetes. It's not randomly distributed either. There's a higher prevalence in people of color. Non-Hispanic Blacks and American Indians and Alaska Natives have higher prevalence. And diabetes screening actually occurs less often in those racial groups compared to whites. So we know less about who has diabetes in the populations of color than we do of the whites. So I think you're starting to get the idea of what I'm gonna say next. So I said, wait a minute. I said, I think I know why there's a disproportionate number of cases and deaths among African Americans in our country, in New Orleans, in Louisiana. And I said, it's because of the comorbidities of diabetes in particular, which triggers hypertension, cardiovascular disease, and obesity. 85 and 90% of people who are obese have type 2 diabetes, but not everybody who has type 2 diabetes is obese. So I wrote a white paper just to get some information out, and our communications department distributed to local media outlets. And these white papers are intended to get information out quickly, but also allows us in the Senate to look at preliminary findings and then do further research. So then I said, well, let's look a little further. And I brought in a colleague of mine who actually, I see she's logged in, Dr. Peggy Honore from LSU Health Science Center. And I said, Dr. Honore, I said, there are hotspots in our country. Now, this is back in early April, middle April, in Georgia, Louisiana, and Michigan, with a lot of deaths. And I said, in particular, the deaths were disproportionately high among minorities. So we talked a little bit about it and did a little research about it. And so we actually did a study. We looked at those particular areas, and our objective was to determine whether COVID-19 in combination with diabetes, hypertension, and obesity was actually a health disparity. Most of the health disparities we think about are chronic diseases, that are diabetes, hypertension, cardiovascular disease, conditions like obesity. But here's an example we thought, and I'll show you in a few minutes that we proved that COVID-19 happens to be an infectious disease health disparity. Maybe one of the first of recent time. Of course, I didn't research a whole lot. And I have on the screen, we have a title page of our paper. I also used a colleague from the College of Nursing, Dr. Katrina Kellum, to work with us, and was fortunate to get the paper out relatively quickly. It was published in May, and it was preliminary findings. Now, let me tell you a little bit about what we found. Okay, we got data on cases and deaths for non-Hispanics and Hispanics from the state health departments in Michigan, Georgia, and Louisiana. We also get information on comorbidities. We calculated crude rates for the pathogenicity is the infection rate, virulence is the death rate of COVID-19, and which we also measure the case fatality rate, which measures the virulence of COVID-19. And then we stratified it by age, race, and comorbidities. And these are the different data sources that we received information from. And so we analyzed the data and we looked at it. So we looked at the United States, then we looked at Georgia as a whole, and we looked at particular hotspot counties. We looked at Louisiana and some hotspot parishes. And we also looked at Michigan and some hotspot counties in Michigan. Now, I've highlighted in yellow some of those areas that were really disproportionately high. The United States morbidity rate, infection rate was 1.79 per 6,7 for 100,000. Daltrey County in Georgia was 1,506 number of cases or people infected by every 100,000 people in the population. And the mortality rate was 94 people died for every 100,000 compared to 9 in the United States. I mean, that's extremely high. Now, I don't have to tell you what's the racial distribution of in the population of Daltrey. It's predominantly African-American. Then we looked at Louisiana, which is not predominantly African-American. It's about 60% whites. But then we broke down the parishes. Orleans Parish is about 6% African-American. Their mortality rate was almost as high as Daltrey County, 1,485 cases of infections per 100,000 people. And the mortality rate was not as high as Daltrey, but it was 73.6 deaths per every 100,000 people. Then we look at St. John the Baptist Parish, which is predominantly African-American. Their morbidity rate was almost as high as New Orleans, and their mortality rate was the highest among all the counties and parishes in the country at that point in time. There was 101.79 deaths for every 100,000 people in the parish. And we see the same thing in Cato Parish, high morbidity rate, relatively high mortality rate compared to the United States, high proportion of African Americans. Michigan had high rates because Wayne County, which includes Detroit, had morbidity rate of 309, again, much higher than the United States, mortality rate high. Oakland County, which neighbors Wayne County, had a higher morbidity rate and a higher mortality rate. And McCabe County also very high. So we initially saw that the counties in which there was this high proportion of African Americans, they had the highest infection rates and death rates. I hate to show you, I'm sorry showing all these tables. So then we just looked at the prevalence of diabetes, coronary vascular disease, and obesity in the same counties that we looked at. Again, obesity, the diabetes rates everywhere are about 10, 11%, a little bit higher in Jefferson Parish than the United States, but it's kind of equal to the United States. The cardiovascular mortality rate is high in everywhere compared to the United States and all the counties. And obesity, and I highlighted a few. This is the percentage of obesity, where in Daltrey County, more than 37% of adults are obese. In St. John the Baptist, 43% of adults are obese. In Cato Parish, it's 40%. So we're beginning to see that our findings, our preliminary findings, are suggesting that the reason why more African Americans and other people of color who are having high infection rates and death rates is because of these contributing factors. In this particular case, particularly cardiovascular disease and obesity. Okay, so then let's break down these areas by race. So Georgia actually has 10 million people. Louisiana has 4.6 million. Detroit has 9.9. African Americans in Georgia 3.4 million, in Louisiana 1.5, in Michigan 1.4. Looked at the cases and that the morbidity rate, the rate at which people got infected in Georgia was 111.07 per 100,000. Whites with 38.67. Do you see a disparity here a little bit? In Louisiana, the morbidity rate, infection rate was 8.74.45 infections per 100,000. In whites, it's 257. I think that's a disparity. And in Michigan, the morbidity rate among blacks was 6.7.5 infections per 100,000, and among whites it was 99. I think you're beginning to see a theme here. The mortality rate in Georgia was 8.7 deaths per 100,000. Among blacks, whites was 3.38, almost tripled in Georgia. In Louisiana, it was 45.39 per 100,000, compared to 11 among whites, 4 times greater. And in Michigan, it was 54.4 deaths per 100,000, compared to 9. So you're beginning to see what's going on. Now we look at the case fatality rates. This is the number of people who are infected who actually die. And you see they're similar. So probably saying, well, what happened here? Well, the white people who died were old. More old people died than young. In the African American population, people of all ages died. So this sort of blends off a little bit. These case fatality rates are very similar. It's because of the disproportionate number of whites who died who were elderly, and mostly in nursing homes, by the way. So we can see that this definitely is disparity in infection and deaths in these areas that we studied. So at the time we did the study, we looked at in Louisiana, what was the percentage of different comorbidities? Well, back in April 16th, hypertension, about 60% of the people who died had hypertension, 38% had diabetes, 22% had chronic kidney disease, 22% were obese. And I thought this is very interesting. Asthma was at the bottom. You would think if you had asthma problems, you would die. Pulmonary disease was near the bottom. I thought that was very interesting. So on Friday, I looked again to see have they changed much. Have changed slightly. Still more than half of the people who have died since COVID started have hypertension. 31% have diabetes. Neurological disease, for some reason, jumped up the list. 21%, 22%, excuse me. Chronic kidney disease, 18%. Obesity still up in the top 5, 16%. And still pulmonary disease and asthma is low. So you would initially think, well, wait a minute, I have pulmonary disease already. If I get COVID, I'm in bad shape. Well, you're in worse shape if you have hypertension or diabetes, to be quite honest with you, which is more prevalent in populations of color than whites. So what our paper really found was, and it's troubling to me, troubling to Dr. Honore and troubling to Dr. Kellum, is that COVID-19 is another example of health disparity. Didn't we have enough of them? So let me give you a couple of definitions. Health disparity can be defined as a higher burden of illness or death experienced by one group in a population relative to another. And this little graphic here says they stem from accessibility to healthcare, occupational exposure, as well as underlying genetic, ethnic, or familial factors. Our data in China indicated that hypertension itself was the most significant comorbidity that resulted in death. Both hypertension and diabetes are long-term, decades, health disparities in our country. So let me give you a more up-to-date definition of a health disparity that's in Healthy People 2020. It's a particular type of health difference that is closely linked with social, economic, and or environmental disadvantages. And that's what I really think is a health inequity, which we'll talk a little bit more about it. Also, Healthy People 2020 define health equity. It's attainment of the highest level of health for people, for all people. Achieving health equity requires valuing everyone equally with historical and contemporary injustices and elimination of health and healthcare disparities. So to have health equity, everyone should be valued equally relative to the needs of their health. So I found this information just and getting ready for this slideshow. As of November 1st, a study was done looking at the standardized mortality ratio. If you take my epidemiology class, you'll learn what this is, but it's basically, you look at the number of deaths and compare it to some standard. Well, they use whites as a standard, so that it's a ratio. So ratio 1 means it's equal. So Asians have a slightly higher ratio than whites, but Latinos and blacks are 3.2 times have a higher ratio of deaths than whites. So the risk of death or the probability of deaths in Latinos and blacks from having COVID-19 is 3 times greater than whites. Health disparity. So then I also found this data, looking at the impact of COVID-19 in African Americans relative to their proportion in their population. And I threw in Mississippi because I was struck by the difference. Data came out just about a week ago that 72% of all deaths from COVID in the state of Mississippi are among African Americans. The African American population only comprises 38% of the population. So if COVID was randomly distributed, you would think that only 38% of the deaths would be among African Americans. In Michigan, 52% of the deaths are from COVID-19 among African Americans, where only 14% of the state population are African American. Georgia, 40% of the deaths from COVID-19 among African Americans. This is very recent data, November 1st, and only 33% of the population are African American. In Louisiana, it's reduced a little bit. So 45% of the people in Louisiana who died from COVID-19 are African Americans, where African Americans only make up 32% of the population. So we can see that this is really troubling to me as a public health and population health researcher to see this unbelievable disparity among African Americans relative to COVID-19 deaths. So, so we found, and people are talking about it all the time, the majority of deaths have occurred in blacks in the United States. I think it's pretty simple. Higher prevalence of diabetes, hypertension, cardiovascular disease, and obesity than any white counterparts. Same exact chronic conditions found in China with the exception of obesity. And by the way, diabetes is a worldwide problem. It's not just a United States problem, not just a southeastern part of the United States problem. And we know that Georgia, Louisiana, and Michigan both have high prevalence of diabetes, hypertension, obesity, in particular in the populations of color. So just to kind of hammer this topic down a little bit, here's a graphic that shows the COVID-19 deaths per 100,000 people in the US. As of July 30th, a little dated, 74 per 100,000 deaths among African Americans, 40 per 100,000 in American Indians and Alaska Natives, 40 per 100,000 in Latinos, and only 31 per 100,000 in Asians. See the disparity in the populations of color. And I found this slide. I just wanted to let you know this has not happened because of COVID-19. These disparities have been here for decades. And I'm going to talk a little bit in a minute, and maybe my colleague, Dr. Honore, who I'll introduce in a second, will jump in. But here are some examples. 30% African Americans, 30% more likely to die of cardiovascular disease. 2 times as likely to die as an infant. 2 times more likely to die with asthma. 3 times more likely to develop end-stage renal disease. 2 times more likely to die from prostate cancer, very high actually. 2 times more likely to die from cervical cancer, and 3 times more likely to die during pregnancy. And we see similar disparities in Latinx Americans. 40% more likely to die of cardiovascular disease, 2 times more likely to die from liver cancer, 2 times more likely to die of asthma, 1.7 times more likely to have diabetes, and 2.5 times more likely to die of hypertension. So one of the things that sort of drives my research is the same exact conditions that have caused these health disparities for decades, we're seeing again with COVID-19. The difference is in the chronic diseases, it takes you years and years and years to die. You die prematurely, but it might take 20, 30 years to die. With COVID, we showed people died in 18.5 days in China. So we're beginning to see people, minority groups dying quickly. So now the alarm bells went off. But what drives me is that these same issues have been going on for decades, and we really haven't done much about it. Another slide, just to let you know, health disparities in comparing blacks and whites. Share of adults who are obese, 39% are black, 28% are white. Adults without health insurance, still without health insurance, 16% are black, 11% are white. This is data from 2014. The death rate for health disease, 211 per 100,000 if you're black, 170 per 100,000 if you're white. These disparities have been here, and they're not going away quickly. So what our studies found is that diabetes, obesity, hypertension, cardiovascular disease, and chronic kidney disease have proven to be a lethal combination with respect to those people with COVID-19. And we also see it in those counties or those geographic areas with a high percentage of blacks, a high prevalence of diabetes, high prevalence of hypertension and cardiovascular disease, and obesity have a disproportionate distribution of cases and deaths of COVID-19. And I think it's a health equity issue. And health equity is a very complex concept, but it involves many things: socioeconomic segregation, racism. There's cultural. There's determinants of health, which we're going to talk about in a minute. The medical access, insurance coverage, different providers, people are poor. So it's a very different concept, and very complex and very interrelated. Now, one last thing, this is my last slide on different COVID things, just to try to, I can't emphasize enough the disparity, I guess is what I'm trying to tell you. This is COVID-19 hospitalization and death rates among people, active EPIC patients by race and ethnicity. These are people who in a hospital system that use a platform called EPICS. So it's easy to get the data. And this comes from the KFF Foundation, Kaiser Foundation. Among whites, who the death rates 7.4 per 10,000. Excuse me, hospital rate and the death rate's 2.3. And in blacks, 24.6, more than 3 times higher, the infection rate, and almost double the death rate. Among Hispanics, it's higher, the hospitalization rate, 30.4, and the death rate's about the same as blacks. And the Asian population, the hospitalization lower and the death rate's lower, still higher than whites. So the disparity is there. So what do we do about it? And Dr. Honore, if you want to jump in, let me introduce you quickly. Dr. Honore and I have been research colleagues and friends for many years. She's at LSU Health Science Center right now. and she's the AmeriHealth Caritas General Russell Honorary Endowed Professor at both the School of Public Health and School of Medicine. She's worked all over the world. She's worked for WHO. She's worked for the CDC. She's worked for the Department of Health and Human Services in Washington, D.C. And she's very experienced. And her experience is in population health and health policy. So her and I make a very good combination. So I'd like Donna Ralman to talk a little bit if you want to jump in to say when. So the social determinants of health are those things that have really nothing to do with your genetics and things that affect your health. And it's compelling evidence that inequities in the social determinants of health, in particular the social economic factors, education, income, housing, social isolation, play an undeniable role in making these populations vulnerable for things like COVID-19, diabetes, obesity, hypertension. This little schematic just shows you a little example of some of the social determinants. It's really felt that only 30% of your health has to do with healthcare you receive and your genetics. 70% has to do with social determinants of health. And so policies over multiple generations have actually set up these structural and environmental inequities that we can link right back to the disparities in social determinants. Dr. Andre, you want to say anything?
Yes, I do want to jump in just quickly and thank you for the introduction. One of the things that I want to point out are these environmental stressors such as racism, pollution, which I know you're going to talk about, that also affect health. And the reason why I bring this up, I'll use the illustration of maternal mortality for Black women. The rate for maternal mortality in Black women is high across all socioeconomic levels. So a Black female, even though we had a case a couple of weeks ago where it was a physician, a Black female who died, a Black physician who died after childbirth. We had another one at CDC. She was a PhD and she died a couple of months ago. So these environmental stressors play a really, really big part. So while we know about the social determinants of health and how important it is to have a good education, how important it is to have a job paying at least a living wage or above, what we're now learning is that there's factors, these environmental factors that are even playing a bigger role in health outcomes, which is very unfortunate. I'm sorry, Pete, go ahead.
Okay, you can jump back in a few minutes too.
Okay.
So here's just a graphic showing the social and economic factors that drive health. And it's economic stability, your neighborhood, where you live, the physical environment, and it's also stress. If you live in a neighborhood that has a lot of crime, there's stress with that affects your health. Of course, Dr. Honoré mentioned education is very, very, very important. Food security, in neighborhoods of people in the low income, they really just have convenience stores with potato chips and things like that, no fresh fruits and things like that, and just carbonated drinks, not a lot of fruit juices. Your community and social context. Or is your community engaged? Or do you live in one of those neighborhoods that everybody has bars on their window, and the minute you go in the house, you lock 3 locks on the door and you really don't ever get out? There's a lot of stress on that. And also the healthcare system itself does indeed play a role on your health coverage. Is it easy to get to a provider? And when you get a provider, does the provider have the cultural competency to take care of you? Particularly see these in Hispanic population, and are you really getting high quality of care? So that's all the things, and these affect mortality, morbidity, life expectancy, healthcare expenditures, your health status, and whether or not you're limited in any daily functions that you do. So these drivers of social and economics have a bigger impact on you than genetics or your health status. And this is another one. This is another graphic I found, and I want to bring up violence. If there's again, if you live in a neighborhood with a lot of violence, studies have shown that just the stress of that you hurry home from the bus stop, or you hurry out of your car and you run into the house, lock the door right away. Those particular, you're afraid to sit by the front room because a bullet might come through, which unfortunately happens in neighborhoods in our city. Then that actually affects your health. And I'm gonna talk a little bit about environment in a minute, but who could ever believe that a situation that happened in Flint, Michigan, would happen in the United States of America, where people turned water on and white chemicals came out and that was their drinking water. So that's an example of environmental injustice. Okay, so we know that vulnerable populations, they work in low-paying jobs without benefit of social distancing, and it's difficult for them to protect themselves from exposure. And Dr. Honore might want to jump in on this. And there's actually a concept called the political determinants of health that helps to explain the policies that have happened over time that has resulted in people having poor health and that affect the population. And I put it to cover the book that Dr. Dawes has written. So unjust environmental policies expose population to also unsafe levels of pollution. And that's a very good example. And I want to talk a little bit about some other research that we're doing that'll kind of finalize what I'm going to talk about tonight. So Dr. Honore and I, in our research conferences, along with Dr. Kellum, asked ourselves, why is St. John the Baptist Parish, St. James Parish, St. Charles Parish, Orleans Parish, Jefferson Parish have such high rates of infection and death among the African-American population? So Dr. Honore says, I wonder if it has anything to do with the air pollution from the petrochemical factories that are in those parishes. So I said, well, let me investigate. So we both investigated and we found the first research we saw about the effect of air pollution influencing COVID-19 outbreaks was in actually northern Italy. And what they found, and if you can remember way back in February, cases in northern Italy increased very rapidly, and the case fatality rates went up sky high and increased with age. And what they found, that the impact was not equal across all Italy, but it was in these regional clusters. And it happened to be those clusters where that was industrialized, and that had industrial facilities where there's a chronic air pollution levels. So the early Italian researchers said, what we found is that if you live in an area that's had long-term air pollution, you had a higher risk to get infected and die from COVID-19. And I said, wow. So I said, well, let's look around the United States and try to find out what's going on. Well, the greatest environmental health risk factor in the US is fine particulate matter, called PM 2.5. It's a pollutant that's emitted by these industrial facilities all over the world. And air pollution is contributing to many disease conditions before COVID showed up. And we also found that they had the same comorbidities for COVID-19 cases and deaths. So they make it worse. They make that lethal combination of the comorbidities actually worse. So long-term exposure to air pollution actually, we found, increases type 2 diabetes risk, which again is a common chronic disease in the United States, across the world. And we linked it earlier to COVID-19 infection and deaths. And we know that long-term exposure to PM 2.5 matter and nitrogen dioxide levels are significantly affected with elevated rates of type 2 diabetes. So we said, let's look at the 11 parishes along the Mississippi River that have petrochemical plants. Believe it or not, in 11 parishes along the Mississippi River, from just south of New Orleans to West Baton Rouge City, there's over 150 petrochemical plants right along the river. And they have relatively high levels of air pollution. And I didn't know this until we investigated that 25% of all the petrochemical production in the United States happens in that 11 parish region. So 11 parishes in Louisiana supply 25% of all the petrochemical products we use in our country. And people for us found high incidence and prevalence of rates of some cancers, and they've labeled this 11 parish area Cancer Alley. There's been some controversy whether it really should be called that, but more people are convinced that it is a geographic area where the air pollution has resulted in high levels of cancers. Now, I want to show you this. We did research, and what we found was an alarming rate of COVID-19 infection mortality and case fatality across these 11 Cancer Alley parishes. And I want you to look really kind of closely at this little graphic. This is the Mississippi River, and it's graded by the percentage of African Americans in that area. And the dark area is 80% or more. And I want you to also notice that and these are the orange dots or the industrial sites, and they're pretty clustered around the dark blues. And I want Dr. Honore in a minute to tell you how experience that she knew about where they sited the plant, and I think in her home parish. And we found differences in mortality are most remarkable across race. Blacks had overall 2 times higher mortality rates than their fellow parish white residents. All along here. Dr. Honore, you want to talk a minute or two?
Yes. What those sites would be called or known as is fence line communities, in that the plants were built more closely to where the Black population lives. So while they may have other races living in all 11 of those parishes, the Black population actually lives closer in the fence line communities, which the only thing separating the plant from somebody's neighborhood is a chain link fence, which is why they call them fence line communities. And there's a lot of research being done on that.
Thank you. Okay, so I just want to show you a real quick table with some of the things we learned, and we're actually hoping to have this research published in the next month or two. And we saw much higher. We compared the 11 river parishes compared to the other 53 Louisiana parishes, and the mortality rate was higher. The infection rate was about the same, and the case fatality rate was higher. And we had some really interesting areas. Iberville Parish, which is just south of Baton Rouge, had a very high mortality rate. St. James Parish had a very high rate, and so did St. John the Baptist, which really struck us to originally look at this. West Baton Rouge had a high rate. The case fatality rate in St. John Parish was about 3 times higher than about 3 times higher than the rest of the state. So not only did we see these disparities in these 11 parishes, we actually saw disparities within the parishes. So not only is COVID-19 health disparity relative to people with comorbidities, if you live in an area that has long-term chronic air pollution, you're actually at higher risk. Now, I hope that you have some questions or comments. And maybe Dr. Honore might want to say a few more things.
If I might add one or two things. This air pollution that has been happening in Cancer Alley has been happening for generations. This is not something that just started. For the petrochemical industry moved in probably in the early 1900s. I think like the first plant was 1904. So between 1904 and 2020, this population has been exposed to these excessive levels of air pollution, which one author has referred to as slow violence. So in contemporary terms, you think of violence, well, there's street violence or, something happens like that. But this he refers to as a slow violence, where this is happening over generations. And we also know that air pollution does impact rates of diabetes, hypertension, cancer, and other things. So it should be no surprise that people living in these communities suffer from those afflictions, but you also need to think about it from the perspective of that it's not just that a person is, kind of like blame the victim. Well, a person has diabetes, they must be doing something wrong. A person has hypertension, they must be doing something wrong. It could very well be the environmental stressors that they are subjected to. Just like I mentioned with the maternal mortality rates being excessive. Also with the COVID deaths among the African American and Latino population. I don't know if you mentioned this, Pete, about the other factors that impact that. So in addition to having these comorbidities, they're essential workers and they're more exposed. They also live in high density households, in addition to these environmental factors that we just talked about. But one interesting thing also happening, and Dr. Foss mentioned this, and that is that COVID-19 as an infectious disease. Worldwide, CDC, WHO, I'd say maybe about 2 decades ago, had begun to focus less on infectious diseases and putting more money into non-communicable diseases, such as diabetes, hypertension, those kind of things. I mean, there was really a concerted effort to put more money into NCDs. Well, now that strategy, they're going to have to rethink that strategy, because COVID has definitely shown us that we cannot ignore infectious diseases, especially something like COVID-19, which is so highly associated with NCDs like diabetes, hypertension, and other things.
Thank you.
Yeah.
Any questions, any comments?
Yeah, thank you so much, both of you, Dr. Foss, Dr. Honore. I'm so glad you could make it tonight. Welcome. So we have one question so far in the chat from Dr. Stephen Farrow, who's here as an attendee. And he says, Dr. Foss, your US data are striking and undisputed. He says, any thoughts on unexpectedly low Caribbean and continental African rates? Do you know whether first or second generation African or Caribbean to US immigrant COVID rates have been explored?
Not to my knowledge. There hadn't been a lot of work. I don't know if Dr. Honore knows anything about that.
Yeah, I serve, I hope I get this right, the Africa and Diaspora Research Network, and I'm on the task force for that. And there was a publication that was just released yesterday. I have an article in there from LSU, but there's a lot of articles in there, and I can send a link to it. But so infectious disease outbreaks is not new to the continent of Africa. If anybody has been prepared for infectious disease outbreaks for a very long time, it's been Africa. They know how to respond to this. They have plenty experience with this, such as with Ebola and a lot of other things. They took it very seriously and were able to avoid some of what we are experiencing here in the US and in other countries. And ironically enough, Africans who were in other countries, such as China, when the outbreak first started, were really discriminated against and treated horribly. I don't know if the thinking was that, well, I don't even want to say anybody thought Africans brought it there, but they were really, really treated awfully. But it was, it was much more contained in Africa than it was in China, in other places in Europe, and definitely with the US. And then again, they have a different system of government than we have. They can demand and mandate certain things. They can, be detained if they're not wearing a mask.
Right.
So it's a different system of government, but they have decades of experience with this.
Dr. Honoré, I've read that in Ethiopia, if the first time they find someone without a mask, you're detained for a couple hours. The second time you go to prison for 2 years.
Yeah, it's
Yeah,
probably extreme.
Yeah.
But if it means saving 250 lives.
Yeah.
250,000
lives. Yeah.
Yeah.
Dr. Farrow, I'm glad you sent in a question. I hope you're doing well.
And actually, Dr. Farrow has another very good question.
Oh, good.
Which is, he says, I should know the answer, but here's the question. Data suggests that COVID kills in large part through cardiovascular damage. So increased cardiovascular disease in fence-line communities is not surprising. However, rural farming communities are frequently dusty with air suspended chemicals. Coal mining communities have similar conditions. Do you know if COVID prevalence in these areas is excessive as well? Do either of you know?
The only thing I can say, I think Daltrey County in Georgia is actually a rural county. It could be more than just African Americans could be farmers, for example. So no one's teased out that data yet. That might be something that needs to be done, Dr. Honoré.
Yeah.
Yeah,
Cool.
to look at the rural areas, yes. Because the focus has really been on the big cities and the urban areas because they're shutting them down. It affects the economy, et cetera. But that's a very good question. I think that's something that we'll look into.
Any other last questions? Yeah, several people have said thank you so much. Please join us tomorrow and Thursday, and thanks again to everyone for being here.
Thanks everyone for coming.
Yeah, thank you.
Thank you, Dr. Honoré.
Thank you, Dr. Paul.